Welcome back again. Our next speaker is Dr. Melanie Thompson. Many of you in the audience are aware of her many accomplishments and activities over the last 40 years. And most recently, in addition to everything she's done here locally, she's been a leader at the intersection of primary care and HIV care, and is one of the co-chairs of the HIV primary care guidelines, also works with the Department of Health and Human Services antiretroviral guideline panels, among others. So she's a real expert in this intersection between primary care and HIV. And it gives me great pleasure to introduce her as our next speaker, and she's going to give you an update about how to best provide primary care for HIV-infected patients. Melanie, thank you.
Thank you, Jeff. Very kind. Yeah, primary care in 30 minutes. Let's do that. Okay. So, there we go. Learning objectives. We're going to talk about optimizing care, a little bit about immunizations, a couple of immunizations, and talk about statins for primary prevention. And a few other things in between. So I want to start with this. This is the HIV primary care guidance from HIV-MA and IDSA. If you don't know it, it's free. You can download it, and there's a little QR code. And I think I have a little bias because I was involved in this, but I think it's a really helpful document. And I want to start out by acknowledging where we are, okay? HIV care in the U.S. relies heavily on Ryan White, the VA, Medicare, and Medicaid, and all of these are under attack. They are currently in jeopardy, but we'll come back to that because I haven't asked for you. All right, so the HIV primary care guidance panel decided to expand our section on optimizing care. This is not new to any of you who provide care, but I think we need to go back to the basics and be sure that we are providing timely and patient-centered care, and we have to provide a stigma-free clinic environment or our patients aren't going to come back, okay? And that means people first, gender-neutral language, staff training on anti-racism, cultural humility, and maximizing our workforce diversity. There, I said the D word, okay? That's right. As best we can to mirror our patient population, it matters. If we can offer extended or non-traditional hours, walk-in care, most of us do offer telehealth. Alternate care venues and street medicine also are important for clinics that can do that. And we need to pay special attention during these transitions of care when there is a vulnerability to falling out of care. So the guidance has 5 great tables. Who doesn't like a good table, right? And I've listed them here, but today I want to focus for a moment on screening for sexually transmitted infections. You're going to hear a lot more about that from Kim Murkowski, but I have to say we are terrible at STI screening, okay? But we can do better. So remember that we're screening for chlamydia and gonorrhea by NAT at all sites of sexual contact, okay? Not just a urine sample. We're also screening for syphilis, and we want to do this at entry to care and at least annually, but more frequently depending on the individual, depending on the geographic prevalence. Here's a hint, it's high here where we're sitting. Past STIs, sexual activities. Screening during pregnancy is especially important. We have an epidemic of congenital syphilis, which is entirely preventable. So it's on us to prevent that, and we do that by going to the Q&A session. Okay, we do that by screening people at the beginning of pregnancy, their first prenatal visit, that is, at 28 weeks, and for syphilis only at delivery, or more frequently if appropriate for that individual. And remember, after we have a diagnosis of pharyngeal gonorrhea, we need to bring those folks back for a test of cure, because it's tricky. Let's talk for a minute about DoxyPEP. How many people are doing DoxyPEP if you're a provider? Whoa, okay, we can skip this slide. So for the couple of you who aren't, the guidelines from CDC are that if there is an STI in the last 12 months, we should consider doxycycline post-exposure prophylaxis for cisgender men who have sex with cisgender men, transgender women, but remember that there is insufficient data in cisgender women for DoxyPEP, and that's because largely of adherence in a trial in Kenya that did not show benefit, but that doesn't actually mean that it can't be beneficial, but it is one of those shared decision-making issues. The dose of doxycycline is 200 milligrams as a single dose, and it should be taken as soon as possible after sex. I encourage my patients to take it within 24 hours, but certainly within 72 hours, and only once in 24 hours. It has high efficacy in preventing chlamydia and syphilis, but less so for gonorrhea, especially in areas where there is a baseline tetracycline resistance. This issue of antimicrobial resistance is important, and it is being studied ongoing. And it is important to continue to screen while people are on DoxyPEP. Number one, it's not 100%. Number two, people don't take it all the time. So there are some encouraging data. I'll just show you one study from CROI this year. This is a study of STI incidence among people who were prescribed DoxyPEP at the Magnet Clinic in San Francisco. And they looked at the time before DoxyPEP versus the time after DoxyPEP. And in this instance, there was statistically significant decline in chlamydia, syphilis, as well as gonorrhea. So these are encouraging findings. Now let's go to immunizations for people with HIV, for adults, I will say with HIV. This is an expanded section in the guidance. And today we'll focus on Hep B and Mpox and measles. All right, so the ACIP adult immunization schedule is shown here, part of it. There's a little QR code for you. It is still available online, okay? In the red box, you will see contraindicated vaccines, and that includes the live attenuated influenza vaccine that is a nasal spray. So that should not be given to anyone with HIV. Also, keep in mind that the MMR vaccine and the varicella vaccines are only for people with CD4 greater than 200. We'll talk about that again in a minute. I'm not going to go through all of these, but we will focus on hepatitis B and Mpox. Okay, so here is a little bit of a CROI update. The hepatitis B CpG vaccine, which is called Heplisav, has been studied in an ACTG study called Beehive. So I want to help you focus on this very busy slide. Beehive was actually two studies. Okay, part A was for people who were non-responders to prior hepatitis B vaccination. Part B was for initial hepatitis B vaccination. And what we saw at CROI were the 72-week end-of-study data for both of these studies. Now, the Group A study randomized people to 2 doses or 3 doses of Heplisav versus an older vaccine, Ingerix B, at a single dose. And but we'll start by looking at the initial vaccine dosing in Group B. Okay, So if you look at this graph, it shows the very high level of seroprotective response. Now that's measured by surface antibody titers being greater than or equal to 10. And you can see at week 12 and week 24, those levels are very, very high. This is unusually high. And this reflects only 2 doses of the vaccine given at 0 and 4 weeks and before the 24-week vaccine was given. And here at 24 weeks, measured 4 weeks later, the seroprotective response for 3 doses was 100%. And if you look at the 72-week endpoint, that was largely preserved through 72 weeks with a 97.3% seroprotective response. And this led, even before the 72-week data, this high response for 2 doses led to the current recommendations from the primary care guidance panel, but also the OI guidelines panel, that the preferred vaccine is Heplisav, 2 doses given at 0 and 1 month. And reminder, don't do this during pregnancy. We don't have enough data. You can also use the recombinant vaccines, but remember we should be using a double dose of the older recombinant vaccines. And if there is a person with a positive hepatitis core antibody, then those individuals actually do need to be vaccinated. You can give them 1 dose and measure their response. In this case, the seroprotective response is over 100, not 10. And if they don't reach that threshold, then you would want to go back and give them a full series. And this is just a reminder to vax and verify, because that slips off our radar sometimes. So be sure to recheck the surface antibody titers after that last dose. Now, let's go back to Group A. These were the non-responders. And the primary results are there on the left at week 28. And what you see there is that in gray, the control arm was not as good as either of the other 2 arms. So 2 doses and 3 doses were superior to the control, but, and this is important, and I think there might be a question about this, 2 and 3 doses were not different from each other at the primary endpoint. But if you look at the 72-week data, what you see is a substantial drop-off in that control arm in terms of seroprotective response, but both 2 and 3 doses of Heplisav maintained very high levels, and in this analysis, 3 doses was superior to 2 doses, both superior to the control. And there's an interesting aspect to this about titers and durability of infection. The higher the titer was at the primary endpoint, the higher the likelihood of a prolonged seroprotective response. And so if those who had very high titers, greater than 1,000, had 100% seroprotective response regardless of what vaccine they got. The 3 doses compared with 2 doses compared with control showed that 3 was better than 2, was better than control for people who achieved 100 million national units per mil at the primary endpoint. So there is a difference, and we may need to be thinking more about titers going forward. So this led to changes in the revaccination recommendations. Now, remember, these recommendations predate the 72-week data that I just showed you, but the recommendation is 2 doses of Heplisav B and to consider a 3rd dose, particularly for people with low CD4 or uncontrolled viremia. You can also use 3 doses of the double-strength recombinant vaccines, and the OI guidelines say you could give a 4th dose, but actually there really aren't any data to support that. And if the non-response was associated with a low CD4 count, then if that CD4 count rises, you may want to go back and revaccinate folks who are non-responders. Okay, let's talk about Mpox for just a second. The ACIP Mpox vaccination recommendation is here. It hasn't changed since October of 2023. The recommendation is 2 doses, not 1, but 2 doses of the Jynneos vaccine for adults who are at risk. And what has been updated in February of this year is that CDC removed transgender and non-binary people from this recommendation, but I've put them back. So originally it read read gay, bisexual, and other men who have sex with men, including transgender or non-binary people, who in the past 6 months have had an STI, more than 1 sexual partner, had sex in a commercial sex venue or in a large public event where Mpox was being transmitted, or sexual partners of any of these people, or people who anticipate being at risk for Mpox. So we should be fairly liberal about vaccinating people for Mpox. These are clade 2 outbreaks that we've been seeing here largely, but now we have clade 1b to think about. This was a CDC health advisory from November about clade B, which is largely seen in Africa, but is very slowly being seen around the globe. Remember that clade 1b affects both sexual contacts, but also household contacts. And this year in February, CDC released this Traveler Health Advisory, which you can download, and recommended enhanced precautions for people who are visiting these nations where clade 1b is more prevalent. And so you should download this, take a look at it. And really the vaccination recommendations are focused on people who might have sexual contacts or intimate household contacts within those areas where clade 1b is more prevalent. And I can't not talk about Mpox without talking about the fact that people with HIV must be prioritized for Mpox vaccination, and we must use a racial equity approach. In the 2023 outbreak, globally, 94% of those who died had HIV, and usually their CD4 was less than 50. Of all people with Mpox globally, almost 40% had HIV, and about 70% were Black. So let's keep that in mind. Unfortunately, we have to welcome back our old friend measles. This is a recent CDC health advisory from March of this year. As of Friday, we now have 483 confirmed cases of measles in 19 states, and this is updated every Friday, so it's gonna go higher. Let's talk about the recommendations for people with HIV who are not pregnant. At the initial assessment, when we first see people, we should assess whether they have had prior vaccination with MMR and whether they have immunity. And the recommendation is that MMR vaccine should be given to people with HIV whose CD4 is above 200 if they were born in the US 1957 or later and have not received this vaccine or do not have immunity to these infections. If you have an immunocompromised person who is at high risk for measles, you may want to consider vaccinating their household contacts if at all possible. We don't give pregnant individuals the MMR vaccine. And this is important, that the people who are not eligible to be vaccinated but who are exposed to measles should receive a post-exposure prophylaxis with intravenous IgG within 6 days of exposure. And remember that we gave an inactivated measles vaccine between 1963 and 1967, and people who received that vaccine may not be adequately protected. So what about us, healthcare providers? I want to just define for you presumptive evidence of immunity, and that is written documentation of adequate MMR vaccinations or laboratory evidence of immunity or confirmation of active disease. And here's what CDC says. Healthcare personnel without presumptive evidence of immunity should get 2 doses of MMR vaccine spaced 28 days apart. And here's the catch about that 1957 date. Even people who were born before 1957 should have presumptive evidence of immunity, and that may mean checking titers. And if they do not, these people also should be vaccinated. All right, we'll turn for a moment to metabolic and other non-communicable comorbidities. I'm only going to focus very narrowly on a couple of things. First of all, just to remind us that cancer now is the leading cause of death for people with HIV, generally non-AIDS associated cancers, and also that people with HIV develop these non-AIDS comorbidities about 10 years before people who do not have HIV. So we really need to be screening and intervening. To prevent both, we should be talking about tobacco cessation with our patients. To me, this is one of the most important things we can do. And yes, it can be effective. I've given you a couple of really good resources to help with those discussions. Now, let's talk a little bit about the REPRIEVE study and its top-line results. You know, this was a large study that was randomized between pitavastatin and placebo for people with HIV, almost 8,000 of them, and it showed that there was a 36% decrease in major adverse cardiovascular events in the pitavastatin arm, and pitavastatin decreased non-calcified plaque volume and progression. So it turns out that if you look at the pooled cohort equation risk score, there was a cut point at about 5%. And below 5%, the number needed to treat to prevent a MACE event was 130 or higher, but over 5%, it was less than 53. So the guidelines from the HIV primary care guidance mirror those of the HHS antiretroviral guidelines panel, and I've given you that reference here. It's a terrific guidance, so you should download that. The recommendation is strongest if the 10-year risk is greater than or equal to 5%, but if it is less than 5%, there is benefit, but you may want to consider other risk-enhancing factors. And for people who have a risk score less than 20%, we want to use a medium-intensity statin. And unfortunately, for people under the age of 40, we don't have evidence to make recommendations about whether they should be on statins. The REPRIEVE study only enrolled people who were 40 to 75 years old, and that is the group on whom the pooled cohort equation also is based. So these decisions need to be individualized. There certainly are people under 40 who need a statin. Let's talk about that pooled cohort equation just a little bit. There is a new publication from the REPRIEVE study. There will be many, many new publications from this study. It is a goldmine. And it did use the pooled cohort equation to estimate risk in the REPRIEVE study and the need for a statin. So now, as those results have been analyzed, it turns out that, first of all, the risk is overestimated in low and middle income countries, and I think that is also one of your post-test questions. So it's overestimated, not underestimated, but what is underestimated in highly resourced countries is ASCVD events for women and for Blacks or African Americans. And so this is a very interesting and important finding, and this paper shows that the PCE calibration can be improved by using multipliers, okay? So for Black or African American women, we should multiply by 2.8. For women who are not Black or African American, multiply by 2.6. And for Black or African American men, multiply by 1.25. So I think this is some practical information that we can use. Just a brief note about diabetes and hypertension and the effects of antiretroviral therapy, particularly INSTIs. So Darcy showed you some terrific data on the emerging story of weight gain and INSTIs. But I think she also showed you the data that where there is substantial weight gain, there is an increased risk of diabetes. So very recently, these two large cohorts have looked at the risk of diabetes associated with INSTI use. So the story is not complete yet, but in these cohort studies, there was increased diabetes for people who were on a current INSTI, in the case of the RESPOND cohort, or who switched to an INSTI in the NA Accord cohort. And these results are often attenuated by weight or BMI. So weight is also playing a factor. So this story is emerging. Also emerging is the question of hypertension. So the jury is out in terms of whether hypertension is more common or not for people on INSTIs. And what you see on the left is the studies that have found that hypertension was more common on an INSTI. And on the right, you see the studies that have found hypertension not more common on an INSTI. And that includes an analysis from the REPRIEVE study. It also includes an analysis, several analyses from the prevention studies that used cabotegravir. So no association with hypertension there. So this study is, this issue is emerging, and we're going to see a lot more studies about this. So I want to acknowledge the HIV/MA, IDSA, Primary Care Guidance Panel, and also the colleagues who helped with this talk and provided slides. But I want to use the rest of my time to talk a little bit about the opportunities we have available to us right now, okay? To end this epidemic, we can't just sit in our exam rooms. I think those days, if they ever existed, and I don't think they ever did with HIV, those days are gone. So advocacy needs to be a part of our job. So what does that really mean? I want to empower you to think of yourselves as having important voices. Clinicians, healthcare providers in all fields are still respected. We still have respected voices, and they are important voices, so don't give up your voice. Right now, we know the global HIV response is under attack. PEPFAR, USAID, CDC, NIH. Right now, there is over $700 million in domestic HIV funding that is at risk in the federal budget that is currently being developed in Congress. So the timing could not be more important right now for us to raise our voices. Likewise, minority populations of all kinds are under attack, including immigrants. So here's the ask. Call your representatives and your senators, and call them frequently. There are so many things we can ask them for, okay? Call them frequently, put them on your speed dial. It's not hard. I've listed here the 5 Calls app. That is not about healthcare specifically, but they do raise healthcare issues. But importantly, it will help you to actually get in touch with your representative and your senators. If you don't know who those people are, then it will help you find them. And I would also say it's important to visit local offices, okay? You don't have to go to DC to make an impact. If you want to do an in-person visit, going to local offices is very effective. And what are we going to say to these people? First of all, the global response has been decimated, and it's going to be very hard to put that back together if there is even the will to do so. But it is important to reauthorize PEPFAR and restore USAID. We need to protect HIV funding, CDC, NIH, research, VA, Medicare, Medicaid, and importantly, stop attacking our people. So I also invite you to go to the hivma.org website and join the Member Advocate Program. And that they will help you in terms of sending emails to elected officials and highlight for you the policies that need to be raised up. So here in the 5th District of Georgia, our Congressman, John Lewis, said the following: when you see something that is not fair, not right, not just, we must have the courage to stand up, speak out, find a way to get in the way, and make some good trouble. So let's do that together, okay?
Thank you, Dr. Thompson. That was excellent. We have several questions around vaccination. First of all, with the isolated core Hep B positivity, should you check a DNA before you do the vaccination, or should you just try the vaccination?
So routinely checking DNA is not currently recommended. There certainly may be instances in which you want to do that. And I'm going to invite you to listen to the last speaker's talk about hepatitis B, and he may weigh in on that too. It's not in his current agenda, but I bet he will. And so I think there are circumstances in which you might want to check a DNA, but vaccinating is important for most people. So I think certainly people who are going into clinical trials, like Jeff showed you, that's a whole different ball of wax. But I think the vaccination part is very important.
And then if somebody's responded to Hep B vaccine, at what interval should you check them to make sure they have a protective response, or should you ever check them?
Yes, you should ever check them. How often? There isn't a recommendation about how often. And I think the people that we know are at higher risk for not having a seroprotective response are people who had lower CD4 counts, people who had uncontrolled viremia when they were vaccinated, older people, for example. And so those people we may want to check more frequently. Some people check annually. That's probably too much for some young, healthy people who were vaccinated with high CD4 counts and so on. You know, the other thing, this issue about titers, we don't generally get a titer. Maybe you do, but you know, I'm generally told it's above 10 or it's not above 10 or whatever. So we can get titers sometimes, and I think if you do get a titer that is very high, that person's probably going to be good for a while. But you know, the lower their titers are, the higher risk for having a loss of immunity over time. So I know that's not exactly the answer you want because you want a number.
And they should be given a booster dose if it falls to less than 10 or less.
Yeah, absolutely. If it falls, then those people need to be boosted, and you again need to check titers after the boosting because they may need a full series and not just a booster.
Switching viruses for RSV prevention, people who are under 75, what do you think would be the indications for vaccinating people under that age?
So just having HIV isn't necessarily an indication, but certainly people who have low CD4 counts or are not have an immune system that is not as robust would be a reason. But our patients have so many other things that would make them candidates for the RSV vaccine, including cardiovascular disease, COPD, asthma, other types of immune deficiencies, and so on. So there is a long laundry list of conditions that would make people eligible for the RSV vaccine. And I think we just need to remember that HIV isn't the only thing that our patients have. So looking at these other comorbidities would be important, and those are often the indication for an RSV vaccine at an earlier age.
Okay. For measles vaccination, is it just the T cell count of 200? Would you vaccinate somebody who's newly diagnosed with a viral load of 500,000, or somebody who's chronically infected who hasn't controlled their viral load? I know those are two different instances. What would you do?
Yeah, so not a lot of data on that in terms of viral load. I would be concerned about someone who has a high viral load. You know, we don't have to vaccinate people as soon as they cross the door of the clinic. I think sometimes for something like this, it's more important to get the person in, get them stabilized, you know, there may be other vaccines that would be a higher priority than an MMR, get their CD4 count up, get their virus down, and then consider vaccination. The issue of someone who's fairly stable but has low-level viremia, I don't have any data about that. I mean, I think uncontrolled virus is a concern, but there aren't any recommendations about that specifically. I think the higher the CD4 count is, the better off you are, the more confidence you can have in vaccinating people.
For healthcare workers who were previously vaccinated against measles, we usually check serology to determine whether to immunize them again. What about our patients? I mean, somebody who was vaccinated 10 years ago, should you be checking to see if they still have immunity and boosting them again for measles? What's the recommendation?
Yeah, so actually, I would say that the MMR vaccine is a very effective vaccine with long durability. So if people are adequately vaccinated, then, you know, 10 years shouldn't be a problem. But I'm beginning to check more levels, actually, and I am finding people who do not have current immunity. So for our patients, there isn't a recommendation necessarily to check titers on every single person. There are some people that you can be sure were adequately immunized, but I think we're going to be left with checking titers on a lot of people. And remember, you can check a measles titer without checking an MMR titer. That's cheaper, and you should also negotiate with your lab to get those costs down, because when I started doing this, I was very surprised by well, I won't say surprised. Were we ever surprised when the cost is high? No. But the cost for an MMR for MMR titers was fairly high, like more than $250, but I was able to get those costs down. So remember, reimbursement is also going to be an issue, and I think being sure that you code it as a high risk for measles may help with reimbursement.
And there's a couple more questions about isolated hepatitis B surface antibody positivity that are going to be addressed in the question and answer section, or at least in the lecture later today. About statins for people who don't meet the reprieve entry criteria, there's questions about, you mentioned, you know, that you might do a multiplier or a modifier of the pooled cohort equation, which is not something that is routinely used in clinical care.
Right.
Other things such as the prevent calculator can be used in people younger than 40 to predict MACE. Has that been looked at by Reprieve? I mean, is that something that we could use as a surrogate instead of having to do a multiplier of an equation that isn't widely used?
So I think that's a great question, and the Reprieve group is very actively looking at these equations, and they have looked at prevent in certain subsets of people, but for those of you who are unfamiliar, the prevent equation is not that new, but a relatively new equation created by the cardiologists and the Heart Association, and it does go down to 30 years of age. And interestingly, it includes some other things like social determinants of health. It also includes kidney disease and some other factors that we know do have an impact on the development of heart disease. So I think it is useful in and of itself, but Reprieve was done with the pool cohort equation. So right now we can't say that a level of 7 by prevent is the same as a level of 7 by the pool cohort equation, but I think we are going to have those answers. I have no idea when, but I know that this is being actively worked on, and other things that the Reprieve group are working on have to do with whether some of the biomarkers that were looked at in Reprieve can be used in an equation for better prediction of cardiovascular events.
And I think that, so that people don't misunderstand, the American Heart Association has guidelines for people who are under 40 who should receive statins.
Right.
The only question is, if you don't meet those criteria and you've got HIV and you're under 40, should you receive them in a more liberal fashion than what the AHA recommends? Because there's plenty of people in their 20s and 30s who need to be on a statin right now, whether or not they have HIV. But does HIV increase the risk further?
Yeah, and I would just mention that there is a guideline from the ACC, AHA, I think it was 2018. It was a statement about HIV in particular and people with HIV, and they identified certain risk-enhancing factors that would increase risk of HIV, of cardiovascular disease. And so, those are things like having a prolonged CD4, low CD4 count, or having prolonged viremia, or having hepatitis C. And so those are things that also go into the equation.
All right, thank you very much, Dr. Thompson. Thank you.